Thank you. Hi, everyone. I'm Brian Raymond from the Kaiser Permanente Institute for Health Policy, and it's a pleasure to be part of this panel this afternoon. And I'm bringing the healthcare delivery system perspective to this conversation, the perspective of a large, integrated, private delivery system, Kaiser Permanente. And as I'll explain, we have a lot at stake with regards to e-health equity. I work in the Institute for Health Policy, as I told you, which is a think tank within Kaiser Permanente focused on long-term health policy issues and concerns. Some of the policy issues are public policy concerns, and some of them are organizational practice change related policy concerns. And e-health equity is more in the realm of organizational practice change. As part of my work with the Institute for Health Policy, I've had the opportunity to work with many of the smart people in our organization who are working on the forefront of advancing health information technology adoption and focusing on the equity concerns that are related. Colleagues like my colleague over here, Winston Wong, are working on these concerns. And I'd like to share with you some of the insight and innovation from our organization around health information technology and e-health equity. I want to talk about integrated delivery systems perspective on the benefits and potential risks of health information technology. Over the course of the next several minutes, I want to talk about Kaiser Permanente's vested interest, or our skin in the game, with regards to e-health equity. I want to share with you some of our research findings in this area, and I want to take a look with you at some options for actionable strategies to make sure that the health IT systems that organizations like Kaiser across the country are putting in place address the needs of at-risk and traditionally underserved populations. But first, let me tell you a little bit about the organization I work for, Kaiser Permanente. Kaiser Permanente is actually a trade name for an entity that comprises three organizations: Kaiser Foundation Health Plan, Kaiser Foundation Hospitals, and the Permanente Medical Groups. Together, Kaiser Permanente operates in 8 regions, serving 9 states and the District of Columbia, and we have over 9 million members today. Oops. Oh, no, that's right. When I mentioned that we have skin in the game, I'm referring to Kaiser Permanente's stake at the intersections of health IT implementation, healthcare delivery, and the communities, individuals, and families that we serve. So we're really at the intersection there with e-health equity. Many of you know that Kaiser Permanente has made a huge investment in health IT. We have an electronic health record system called Health Connect. It's deployed in all of our regions, in all of our facilities across the nation. That makes us the largest health IT system in use today in the United States. And Kaiser continues each year to make a huge investment in this health IT backbone each year. Health IT in Kaiser, again, is called Health Connect, and it integrates appointments, registration, billing, and back office healthcare functions. It supports ancillary services, inpatient and outpatient care, and includes a data repository as well as a patient portal. I'll pause here and let you soak in these statistics that illustrate the magnitude of Health Connect use today. And for the non-geeks in the audience, a petabyte is 10 to the 15th power of data storage. Take my word for it, that's a lot. So Health Connect is literally transforming care for Kaiser Permanente members. As a Kaiser Permanente member, I have access to secure email with my providers, online access to my test results, online appointment scheduling and prescription refills, and it's a well-kept secret, but today members can even schedule video appointments with primary care providers. And today in Kaiser Permanente, care is not just delivered in person, it's delivered through secure email and by telephone. Today, a third of our primary care visits are conducted by email. And you can see by this chart the magnitude of that change over the last decade since we implemented Health Connect. And care and service in Kaiser Permanente is going mobile, and it's really taking off. In 2012, 27% of the Health Connect transactions were conducted via mobile devices. So yes, Health Connect is redefining access for Kaiser Permanente, it's transforming care for our members, and it's empowering our patients. And one of the ways the impact is showing up is in terms of quality improvement. Although the contributing factors are many, Health Connect is clearly enabling higher quality performance in our organization. These charts show quality improvement on a number of fronts. The vertical bars highlight improvement from the beginning of Health Connect implementation through 2012. All of Kaiser Permanente's Medicare plans are in the NCQA's top 10 out of more than 400. And our Southern California plan has been the top rated, #1 ranked plan by the NCQA for the past 3 years. But despite the quality improvement that we've experienced and our award-winning quality leadership, health disparities persist among Kaiser Permanente members. We're not #1 in health for everyone, everywhere. This chart highlights the hot and cold spots of obesity prevalence among our members. And this is the San Francisco Bay Area, where I grew up and I currently live. And not a surprise, the areas of high obesity prevalence correspond with low-income communities and communities of color. This map shows the trends for asthma. It's pretty similar. And diabetes. And hypertension. So despite our massive health IT investment and market-leading quality of care, health disparities persist in our population, and that's a major concern for us. So this is our stake in the game, and our stake in our skin in the healthcare, health disparities and e-health disparities work. As an integrated delivery system, we understand that our approach to health information technology can either narrow or widen health disparities. That's because the benefits of health IT can easily disproportionately accrue to individuals with both access to health information technology and the resources and skills needed to use them. That's what I call meaningful access. And the risk to people without meaningful access, the risks are being left behind. Being left behind in terms of quality improvement, some of the quality improvement that I told you about, and being left behind in terms of consumer engagement. So over the past few years, Kaiser Permanente researchers have really focused in on better understanding the benefits of Kaiser Permanente Health Connect and the potential disparities in its use by our members. A study by researchers published in Health Affairs found that secure email by Kaiser Permanente members was associated with a 2 to 6.5% improvement in HEDIS measures, hemoglobin A1C, cholesterol, blood pressure, screening and control, all improved. But this highlights a potential healthcare disparity between the users and non-users of our secure email service. And again, that's a major concern for us. The researchers who conducted this study, they didn't conclude exactly why secure email improved quality, but some of the factors that they consider are at play include increased continuity of care, increased patient-provider connectedness, and increased patient engagement. And that all makes sense. Secure email has the potential to do all that. Another group of researchers found that Kaiser Permanente members who are registered for access to our personal health record are more likely to be white, non-Hispanic than the non-users of the system. But online registration is just the first step in using our patient portal. Another study, this one in Northern California, found that African Americans and Latinos in Kaiser were more likely than non-Hispanic whites to request a password for accessing our patient portal, but never using it. So they took the step to request the password, but they never logged on to the system after that. So that's a concern. And a study of Kaiser members in Georgia found that education matters. Kaiser members with a postgraduate education more frequently registered for access to our patient portal than members with a high school education or less. We have other research findings that I won't share, but together these findings really document to us that there are potential e-health disparities among our membership. And that's a concern that we really need to keep on our radar and track and address. So now that the indicators of potential e-health disparities are on our radar, we have the challenge to identify actionable strategies to ensure that health IT addresses the needs of at-risk and traditionally underserved populations. Without an explicit strategy, many of the technology solutions that are supposed to improve quality and access for all of our members may disproportionately benefit a subsegment of our population. And that subsegment is more likely to already have better health and already have better access to health care. So what do we do about this? One way to look at our options to promote e-health equity is by segmenting the at-risk population. This takes into the notion that one-size solutions don't fit all. So here's one way that this might look. The haves are people who currently have access to information technology, computers, tablets, smartphones, and they would consider using it for health, and maybe they already are. The wants want access to e-health, but for one reason or another may experience a barrier to it. Maybe they don't have broadband access at home. Maybe they don't have a data plan for their smartphone or cell phone. Or maybe there's a literacy challenge that they or their family faces. There's a barrier of some sort. They would be interested in accessing e-health, but they need some assistance. And then there are the don't wants. These are the individuals who just aren't interested in using information technology for health. Many of these people in the don't want category are like my parents. who have no interest in using a computer, although they bought one 15 years ago, took a lesson at the community college, and then it's sitting in their study gathering dust. They haven't used it. And they don't want a smartphone. And they prefer face-to-face encounters with their providers. And that's okay. But we do have to acknowledge that that segment of the population exists. So by segmenting at-risk populations, delivery systems like Kaiser can tailor strategies to minimize the risk to at-risk populations. So for the haves, the folks who already have access to technology, the strategy here should focus on content and functionality. If it's a patient portal, we're going to make sure that that patient portal has useful information, accessible information, and information that's relevant to that population. And marketing is also important. Individuals in this segment may not be aware that the patient portal exists or that it may have content that's valuable to them. For the want segment, for people who want access but face a barrier, this strategy could focus on increasing technology access and skill development. This might look like a broadband or computer access program in an underserved area or a computer literacy program. A secondary strategy for this segment is to offer alternatives to more high-tech care. And that's important because until individuals in the want segment actually obtain meaningful access to health IT, organizations like Kaiser need to continue offering lower tech access to healthcare. We can't just move directly to high-tech solutions. We need to continue offering the low-tech solutions. And for the don't want category, here we need to offer alternatives as well. Just like for the wants, we need to offer them alternatives. And here the alternatives to e-health are traditional in-person visits, traditional phone visits, and print material. So all those need to continue in a high quality manner. And for this segment, we can also target marketing to raise their awareness of the potential value of e-health to them. And maybe if it's not to them, it's for a caregiver of theirs. A caregiver can get proxy access to our health information system for them, or one of their family members or one of their children can access the system on their behalf. So maybe they're not interested themselves, but they have a proxy who would be interested in using the system on their behalf. So at Kaiser Permanente, we don't have all the answers to e-health equity. But we are recognizing that we have our skin in the game with this regard, and we have a lot at stake. And we do recognize that we have a role to continue playing in terms of advancing research and better understanding both the benefits of our health information technology system and the potential risks that it poses. And we also are continuing to explore actionable strategies that can be segmented to address at-risk different segments of the at-risk population. So our work is really continuing in this space. So thanks for your attention. I appreciate it.